now we're going to see the different types of bradyarrhythmias. On a separate video, we have the management or acute management of the bradycardia. Here we are going to see specifically the pathophysiology of every bradyarrhythmia. So we are going to see just sinus, bradycardia, the AV blocks, atrioventricular blocks, and the Ecg Node syndrome. So remember that for bradycardia, the best initial treatment, that is if the patient comes certainly with symptoms or without symptoms anyway, it would be atropine. The most effective treatment for long term would be a pacemaker. Now there will be some situations in which we are not going to do this, depending on how is the patient and what is the cause. So in sinus bradycardia we will not treat this. Sinus bradycardia is a sinus rhythm with less than 60 beats per minute. If it is asymptomatic, we will not treat it. If it is symptomatic, then we can put a pacemaker. First, for the acute event, we will give atropine. Now, if the patient has Ecg sinus node syndrome, this is that the sinus node is like failing, it's like sick. So remember that the heart has automaticity. So when the atrial node is not firing, other group of cells can fire. Like the next one in line is the atrioventricular node. So we see this as a P followed by a QRS and the T wave, and it's taking too long to that this node reacts. So then a long pause, P, the QRS, T wave, so long, and the P wave, etc. So there will be a part in which we have a very wide this interval between the T and the P, that the P never comes, and so a foci of automaticity is going to be disparated. In this case, the next in line is the atrioventricular node. So we will see a morphology of a P that is different. Usually it's just a QRS complex because the P wave is actually negative side, because it's from here, from the atrioventricular node. Now the depolarization goes all to the wave. So the two will see it on the opposite side. The depolarization goes here instead of going that way. And so we will see that the P wave is negative, but will be exactly on top of the QRS. So we will just see the amplitude being decreased. So we would not see a P wave. So we see like P, and then a QRS. But here we need to be very careful with not confuse this with a atrioventricular node block. And then as time goes by, we will see that then maybe the next bit continues to be just the QRS complex and then the T wave. And maybe in the next one we'll see that the P wants to, teleologically speaking, wants to come again, and so it regresses to sinus rhythm. This is Ecg sinus node syndrome. This would be associated with secondary tachycardias or bradycardias. Also, the patient can develop atrial fibrillation, in which case we will need to anticoagulate also the patient, and certainly the pacemaker. Alright, now the atrioventricular node blocks. These are the most interesting ones. First, the findings on EKG. We have first degree, second degree, and third degree. Now the second degree is divided into Mobitz 1, also called Wenckebach, and Mobitz 2. So the Ecg findings that we will see on the first degree AB block, we see just the P, QRS complex, T wave, etc. And is regular rhythm. The only abnormality that we see on the EKG is that the PR or PQ, it is called PR, but it goes from the P, from the beginning of the P to the beginning of the QRS complex. The QRS complex could begin with a R or with a Q. Well, so the PR interval is prolonged, is greater than 0.20 seconds, like one big box. This is the only thing that we will see on the first degree AB block. And if the patient is asymptomatic, there is no need to treat. If it is symptomatic, we would put a pacemaker. Well, usually patients are not symptomatic, so that would be very rarely. Alright, the situations in which we can have first degree AB block is most of the time just as a result of calcium channel blockers, beta blockers, digoxin, or just too much vagal stimulation. That are among the most common causes, but also we can have like cardiomyopathies or some other reason, like maybe degenerative changes seen on aging, etc. Alright. In the second degree AB block, we have, for the Mobitz 1, we have the PQRS complex, the T wave, PQRS complex, the T wave, all these. Here, the PR interval is being enlarging. So maybe the first one measures, let's say, 0.20. So it's not greater than 0.20, so it is alright. But the next one measures, let's say, 0.24. And the next one, PR interval, measures 0.28, whatever. So we are seeing that the PR interval is getting larger and larger and larger. So this will be an irregular rhythm. Until there is a part in which we see no P wave and just a QRS complex and then the T. So this is the maximum PR interval. We have no PR interval here. And then it would return again a P, QRS, T, P, QRS, T, but again the PR is getting larger and larger and larger. This is called Wenckebach, and we have 1, 2, 3 P's to 1, 2, 3, 4 QRS complexes. So this is a Wenckebach 3 to 4. The most common are 3 to 4 or 1 to 2. Always here we have how many QRSs we have, and here how many P waves we have. Always this number is going to be one number greater than this one. This in comparison to the Mobitz 2. Here in Mobitz 2 we have the PQRS complex T, and the PR could be normal or enlarged, but the issue is that suddenly we would have a drop beat here, a QRS complex without a P wave. So it's exactly the same, just that the PR interval is not getting larger and larger and larger. It could be enlarged, it could be normal, but it's not enlarging. This most often is just to some degenerative changes. This is for ischemia, most of the times. Yes, we also have other things like massive calcification of the valvular annulus of the mitral valve or aortic valve, myocardial infarction, diaphragmatic myocardial infarctions, as well as here. This can also be caused by myocardial infarctions, but also the Italy's maybe other infiltrative diseases, etc. Here, if the patient is asymptomatic, there is no need to treat. But MOVITS 2, we need to treat it with a pacemaker, even if the patient is asymptomatic, because the patient has risk to go to the third degree AV block. If the patient is symptomatic on the MOVITS 1, we would treat clinically with atropine. Now, a little bit more of the comparison between these two is the damage here on the MOVITS 1 is suprahysial of the as of his on the AV node. Here it is infrahysial or intrahysial. This is infranodal, this is supranodal. Most of the time the frequency on the MOVITS 1 would be above 45 beats per minute, and the QRS complex is usually narrow, so less than 0.12 seconds, as opposed to MOVITS 2. Well, yeah, it would depend if it is infrahysial or intrahysial. If it is intrahysial, the QRS complex is narrow, but if it is infrahysial, it could be a wide complex QRS, and the frequency would be less than 45 beats per minute. Alright, now for the third degree AV block, we have the atria go from one side, the QRS, the ventricle goes to the other way, because here we have complete blockage of the ventricles of the atrioventricular node, so we have no communication between the atrium and the ventricle. So we use CA frequency of P waves, P wave, P wave, and other frequency of QRS. Here I have a QRS complex, QRS complex, QRS complex. Most of the time the frequency of the P waves is very higher, so it's something like this. You will see all sorts of things like T waves on P waves on top of T waves on QRS. You will not see any pattern, so you will recognize it. This is the most severe. This is due to degenerative changes. This is called Legendre disease, but also infiltrative diseases like myocarditis, sarcoidosis nodules, tumor, tuberculosis, myocardial infarctions, etc. So in the third degree AV block and second degree AV block, MOVITS 2, pacemaker, even if the patient is asymptomatic. But certainly a third degree AV block, the patient will be symptomatic. MOVITS 1 and in first degree AV block, no treatment unless they be symptomatic. In first degree AV block, the PR interval is enlarged, but is just one number, is not getting larger. MOVITS 2, the PR interval is getting larger and we have a drop it. MOVITS 2, we just have a drop it. The PR interval could or could not be enlarged. And on the third degree AV block, we have the atria going to one side and the ventricle on the other side.